Hey, it's Carrie from Wrap Your Head Around Silks. This is the Expecting Aerials podcast, now with the Digitent Network. How's it going, guys? Thanks so much for tuning in. Before we get started, I am so excited to announce that I will be partnering with Sweet Retreats and host an intermediate aerial dance workshop intensive June 21st through the 28th of 2025. I am so excited. 7 days of aerial and flow and camaraderie and jacuzzis and pools and jumping in the ocean and so much fun. I would love for you guys to join me. I've got plenty of students in the 2 cities that I've worked in, but then outside of that, I would love to meet you. So early bird starts December 1st, and I will keep you guys abreast of all of the details. We have Roll It Out every Tuesday and Thursday at 7 p.m. Pacific. We hit the mat with balls and foam rollers. We gossip, we laugh, and we maintain our aerial muscles. I am out of chronic pain because of this 2-hour blocks in the week. And I really want to get to know you guys and then really help you be healthier aerialists. We have a comprehensive course. It will give confidence to those who train on their own, or if you have spotty access to instructors where you live. It is a comprehensive beginner to intermediate silks course, 12 modules. I made it for you guys. I hope you join me there. And then, of course, aerial rehab for the postpartum, post-injury aerialist. If you need to get back in the studio, but you need steps to get there, it's meant to be the bridge between PT and your favorite aerial class. We have Dr. Janae Davis, who is our resident. Oh, yes. Hello. That's hello from a bean. Our resident OBGYN, who I love to have on here. She is from my hometown. We never crossed paths, but she's like my favorite doctor ever.
It's almost my birthday.
It is almost Bean's birthday. And, with ectopic pregnancies coming up more and more in the news with stories about women dying from ruptured ectopic pregnancies, I thought that I would ask her to come on and explain exactly how an ectopic happens in the body, what the treatment is, and why these stories might be happening across the country. All right, my friends, let's get started. Well, since I talked to you, lots have happened in this country.
Yeah.
The thing that has become more commonplace to hear about is ectopic pregnancies, because people are starting to be like, well, wait, what is that? And I'm like, hello, it's a thing. So what I wanted to do, listeners, is to get Dr. Janae back on the podcast
listeners,
do what she does for us with all the things and really break down how it happens in the body. Like, you're trying to get pregnant. Your pregnancy test says you're pregnant. And then it's not right.
Where is this pregnancy?
Where is this pregnancy? So if you could do like the 101 for us, and then I'll jump in.
Okay, yeah, no worries. So I think in the past we've probably talked about normal physiology, normal anatomy. So I will just truncate that into some 101 language. So you need just a couple things for pregnancy to happen. You need an egg that starts, that ovulates, which means it pops off of your ovary and falls down behind your uterus. That's ovulation. You need a sperm that left a penis or some space and ends up in your vagina or in your uterus. And you need that egg and that sperm to connect with each other in the fallopian tube. That's what you need for pregnancy. So when we have ovulation, I always tell people, think about an ovary as like a tennis ball, like a hard tennis ball. And think that you had a piece of saran wrap and you sprinkled pepper all over that saran wrap. That piece of saran wrap with pepper you take and wrap around the tennis ball. That is what an ovary is. There are no eggs in the middle of an ovary. They are only on the outside of the tennis ball. It's each piece of pepper is an egg. Every month, your body picks one piece of pepper and decides, this is interesting. I want this one to be the one we're going to choose this month. That's because we have all of the eggs we ever were going to have when we were born. They're all just sitting around on the outside cortex of our ovary, but it's stuck like a piece of pepper would be stuck on saran wrap. You can't just get it off there. So your body picks one of them and it starts to secrete a hormone that makes basically a blister on your ovary, it starts to secrete fluid around that piece of pepper so that that piece of pepper can float in a bubble. So it'd be like if you had a piece of pepper in the middle of a balloon, of a bubble balloon that you blew out of your mouth, right? It's just a piece of pepper floating in a 3 to 5 centimeter cyst. This is my pet peeve. My doctor said that I get cysts on my ovary. Happy for you. You ovulated. You've been doing that every month since you were 12 years old. Stop talking to me about your GD cyst. Nobody cares. Nobody cares. Nobody cares. Nobody cares. Okay. You just ovulated. Who cares? We care about masses on ovaries. We care about like bad stuff. We don't care that you got a cyst. Good for you, you ovulated. That's just me having a note about people from the ER showing up acting like they're dying and you're not dying. You ovulated. Okay. So we pick that piece of pepper. We make a blister around it. It's 3 to 5 centimeters. That can be as big as you putting your index finger and your thumb together. That's how big about 3 centimeters is. A little bit bigger than that's 5 centimeters. You can have that on your ovary and it's totally fine. Once it gets big enough, just like if I was blowing a bubble with bubble gum, once it gets big enough and I keep blowing, what happens to it? Pop! It blows up. You burst your cyst. You're supposed to. It's the only way I can get this piece of pepper off of this saran wrap is if I blow a blister around it that's full of fluid, I blow it up, and all that fluid plus that piece of pepper falls down behind my uterus. Are you with me?
I mean,
you can't.
I'm trying.
Right. You can't believe it. That is called ovulation. That is getting an egg off of my ovary. All that fluid flows down behind your uterus. It does not jump into the fallopian tube. That water and piece of pepper goes behind the uterus. Both of your fallopian tubes have little cilia. They're called cilia. They're like little hair-like pieces that flow in a direction that will allow that fallopian tube to suck up like a vacuum with those tiny hairs that are sucking up this fluid, hoping that they also suck up that piece of pepper. That's what happens every single month. So if you blow an egg off of your right ovary, your left fallopian tube could be the fallopian tube that picks up that egg. You don't have to have it from the same side. Does that make sense?
Yes.
Because it's just fluid all going back there. Hope there's a piece of pepper. One of these tubes is going to pick it up with these cilia. They're called cilia, but they're like hair-like structures that suck up and move down the tube. Let's move it down the tube, flow, like a nice wheat field. Like, oh, wheat field in a wind. Oh, here we go. Go egg. Okay, so it's going down the tube. Then sperm ends up in your vagina. However it is you do it. Turkey baste it. A man goes in there. You take a condom and flick it up inside out. Whatever you're doing, semen is going to end up in your vagina. It travels through your cervix. It swims towards the fallopian tube. It goes into your fallopian tube, and in the middle of the fallopian tube, it meets your egg. If things are absolutely perfect, best egg ever, best sperm ever, best fallopian tube ever, best day ever, best sunshine ever, best serotonin, best sex, best orgasm, best, 20%. You got a 1 in 5 chance of getting pregnant. So people, I don't know what happened. I've been trying for a month. And nobody cares. How long does it take you to roll a 6 on the dice? Okay, don't come to me talking about I failed out of Vegas because you didn't roll a 6 the first time. Stop talking to me. It's wrong. No, it isn't. Okay, best case scenario, best egg, best tube, best sperm, 20%. Max, best case scenario. But the last time we tried it only took us 1 month. I'm happy for you. You rolled a 6 the first time. There's nothing wrong with you. Don't talk to me. There could be something wrong with you, but stop talking about it after 1 month. We don't want to hear about it. We're not running all these labs and tests and figuring out what's wrong. There's nothing wrong with you. Okay, still. Oh, yeah, that's another pet peeve. That's pet peeve number 2. Okay. So that is normal ovulation and sperm connecting. If your egg does not meet a sperm, it just travels, keeps going. Oh, what is that big abyss? It's the uterus. It jumps into the uterus. There is no sperm. It doesn't implant. It goes out, I have a period, and I bleed it out. Too small for you to even see. This happens every single month. I'm going to get estrogen. Estrogen stimulates my ovary. Hey, let's get a blister around that piece of pepper. It blows up a 3 to 5 centimeter cyst. Do not call me. The cyst bursts. The fluid goes down behind the uterus, and so does that piece of pepper. Your little suction fallopian tubes go there. Try to suck it up. Them little wheat field cilia. Go. Takes the egg. Go down the tube. Here comes the swimmer. Oh, no. Which tube do you think we should try? They try both of them. You think, what is that big round thing up there? It's an egg. It runs into it. If the stars have aligned, then they will meet together and form, if not, the egg keeps going, you have a period, and you do it all again every month.
Why don't you have your own show? Seriously.
I should have. I could draw these little cartoons. Where's the egg? Where's the egg?
You guys should see her hands. Like, I'm pretty sure if you had a kid in front of you, they would just be in it. Because you're like this and that.
I'm in it.
Oh my God, you're so in it. Now,
here's the problem. When people, not millions, about 50 years ago, we were like, hey, we don't really know how to tell if somebody got pregnant or not. So we're just going to wait for us to miss a period, wait for you to start puking in the trash can and your boobs to start hurting and we'll think you're pregnant. Well, nowadays you can literally wipe his thing off and go pee on a stick and almost know that you're pregnant. Okay. Like, we have tests now that tell us so quickly that somebody is pregnant that everybody thinks our miscarriage rate is going up, but it's not going up. It's the same as it's been forever. But I'm serious. So we have all these chemical pregnancies, which is on my pregnancy test, it said I was positive, but then I get a period. So you have people come in and say they've been pregnant 6 times with no documented ultrasound pregnancy, no quant level, no blood level that said they were pregnant, but they keep peeing on sticks that say that they're pregnant. And so we have to be really, really careful, number one, because it causes such anxiety in people, which is like my pet peeve. Like, stop scaring everybody. You know what I mean? Like, it really is. How disheartening is that for you to, as soon as you pee on a stick and you see 2 lines, your entire life has changed. Whether it was a wanted pregnancy, a surprise, or whatever it is, an infertile patient, whatever. Like, when you see those 2 lines on a stick, everything about your future you think about changes. And there is real and significant loss associated when you get a period after you've seen those double lines. So I spend a lot of time talking with people about expectations, and that 50% of the time when an egg and sperm touch each other and create some hormone that might turn a pregnancy test positive, that's a chemical reaction that's happening that hasn't implanted into your uterus yet. That's a chemical pregnancy that shows our test that, oh, these 2 things have happened, but it's not an implanted, something that significantly will impact their future fertility. That's what we're talking about. Like, are you having a trouble getting pregnant? Do we need to do a workup to make sure your chromosomes are okay? Is his sperm okay? Like, all of those things. Do you have a bleeding disorder? Do you have a thyroid disorder? Are you pre-diabetic? Like, all these things that we would go through, we don't have to go through on chemical pregnancies. So early pregnancy, really early pregnancy, before I would see it on an ultrasound, is what we're talking about. And when we diagnose most of the time ectopic pregnancies. So ectopic pregnancy, the definition is anything that implanted itself not inside my uterus. So any of those spaces that I talked to you about, where am I at? On my ovary, when that pops off there, right behind my uterus where that egg went, in the fallopian tube, which is the most common place for an ectopic pregnancy, is that my egg and sperm got together, but they stopped moving at one of those places before it implanted inside the uterus. That's what an ectopic pregnancy is. If we have really, really, really early pregnancy, I can't see it on the ultrasound. I can't see it at all. If you're 4 days pregnant and I scan you, I see absolutely nothing. If you're 6 days pregnant, I see nothing. If you're 4 weeks pregnant, I see nothing. What I can see is blood work that tells me, oh, your pregnancy level in your blood is elevated, even though it's not to the level that I should be able to see it. So that is a pregnancy of unknown location. And that's when people show up to the ER and we have to start doing some really significant communication with our patients and understanding about what our expectations are in early pregnancy until we get to the point that we should see it in your uterus. When you should see it in your uterus, for some people, isn't until around 6 weeks. Some people see a sac, but not anything else in the sac at maybe 5 weeks. That could be a completely normal pregnancy. At 5.5 weeks, you might see a sac and a little grain of rice with no heartbeat, no movement, no nothing. That might be normal pregnancy with no heart rate. 6 weeks, you might see a sac, another little sac, which is a yolk sac, and then a little piece of rice and no heartbeat. Then you might see a sac, a yolk sac, a little piece of rice, and a little flick. And you might not see that till 6.5 weeks. So the time between 4 weeks when you saw absolutely nothing and 6 weeks when I needed to actually see something moving, that's a lot of time in there that causes anxiety for people. And we don't know where your pregnancy might be, right? Because we might not be able to see it in the ultrasound. So we get blood work to say, my expectation for a normal pregnancy is that if I draw your blood for pregnancy hormone levels, it's called a quantitative HCG. If I draw your blood level every 2 days, every 48 hours, it should rise by this certain amount until I get to the point that I should see it, in which case that level hits around 1,500 to 2,000 is when I should see it. But when you're really, really early, your level might be 200. So guess what it's going to be in 2 more days? 400. And then what's it going to be? 2 more days, 800. Then what's it going to be? 1600. I don't even see it for another week. So we're getting blood levels to make sure that we have an appropriate rise so that we can say most likely this is in your uterus, because ectopic pregnancies don't typically have a normal HCG rise. That's why we have to keep checking people's blood every 48 hours to make sure that it's reassuring for us until we can get to the point that we see it in the uterus. I see your face, so I'm going to let you ask me some questions.
Oh my God.
You're welcome.
Did I ever go to school? Because I didn't learn any of this.
This is, yeah, girl, this is what happened. Yeah, this is what happens.
You want to say hi to Dr. Janae again?
Hi, baby. No, okay, that's okay.
You want to hug on mama?
That's okay.
Okay, so, I didn't expect you to say all that because...
Sorry.
Does that mean, in your opinion...
Sure.
We shouldn't be testing that early, necessarily? Or should we be? Because...
Testing for, like, should people go pee on a stick before they miss their period?
Yeah.
I think if people don't understand... I think it depends on somebody's emotional state, right? So I have people who are so anxious about being pregnant, so excited. They are so disappointed to see that. Some people can't stand it. They can't wait until they'd miss a period, until they'd be 5 or 6 weeks. So it's information, but I always want people to understand the relevance of the information that they're getting. So I wouldn't tell a person they can't do it. I would say if you have anxiety, you probably can't stand to wait, right? Because you just can't stand to get that period. It's just... like every day that passes is really hard for people who are trying to get pregnant not to know. So I don't want to say don't do it. I want to say understand that it doesn't impact your future fertility or, have implication on your reproductive potential just because you had a chemical loss. Because you'll come in there and say you were pregnant 12 times when really it's just an egg and sperm that talked to each other for a second and didn't like it. 50% of pregnancies where the egg and sperm talked to each other didn't like it. Something just wasn't right. There's nothing wrong with the mom, nothing wrong with the dad. They have completely normal pregnancies when the egg and sperm like each other. And they don't even miss a period. Like they have a regular period. They just happen to have had a positive pregnancy test. You would have never seen those before we got these tests. This has been happening the same, and people just got a period and didn't know that they...
I mean, pregnant. when I was before she was born, we weren't like air quotes trying with intention. Mm-hmm. So I never took tests until I was like trying. Something. Yeah.
Remember when I said Goo Goo Gaga don't do a podcast.
Oh, yeah. Yeah. And you were in my belly telling me things too. I remember because you were punching me. Huh?
Like.
Oh, okay. Not now. Because I want to, oh my God, of course, now my brain is moving. So I don't even think I understood what a chemical pregnancy was before you just explained it.
Yeah.
Do you feel like it should be named chemical pregnancy?
Yes, I do.
Because it is actually, you tell me.
Because the implication of recurrent miscarriage is completely different than recurrent chemical pregnancy. If we have somebody who has recurrent miscarriage, so that would be multiple, depending on which society you talk to, 2 or 3 consecutive, not inconsecutive. So you can have a miscarriage and have a full term, miscarriage and have a full term. Those are not recurrent pregnancy loss. We're talking about consecutive. Typically, if you have 3 over 6 weeks that have documented by an ultrasound, now I need to do a workup on you. If you have 1 loss that's beyond 10 weeks, I need to do a workup on you to make sure that you don't have a chromosomal abnormality, a genetic abnormality, or that you don't have a bleeding disorder, essentially, to make sure that you don't have a problem with your future implantations. Because then at 10 weeks, it's usually not so much a genetics issue with them just not liking each other. It's something more than that because you made it to 10 weeks, right? Chemical pregnancies, on the other hand, do not have implication on people's future fertility. So the workup is not indicated. So people come in with 3 chemical pregnancies, i.e., I got my period. It's the same thing as I got my period, wanting to spend a bajillion dollars on a workup that is not indicated, because if they hadn't taken a test, they would have just had literally a period on the 28th day. So the reason why I think it should be called that is because the implication to your future health is completely different. That does not mean that I think that we should emotionally downgrade a person's the impact that it had on a person, because that is a loss. As soon as you see those 2 lines, it's still considered a loss to that human, to that mom, to that dad, like still considered a loss. But I spend an exorbitant amount of time reassuring them that that is not have anything to do with their future pregnancy considerations.
I just talked to friends who had chemical pregnancies, and it ends up feeling like a miscarriage to them.
It feels exactly the same, because when you pee on the stick and you see 2 lines, you see your son or daughter graduating. You see, shit, we have to get a van. Shit, we got to move. That's what happens.
But truly, the implantation from your definition hasn't been there. I don't think people know that. You know what I'm saying?
Yes, I don't think they know that.
think it's a miscarriage when really it's not an implanted
egg. Or super early. You can start having trophoblastic cell come from before you've implanted. So yeah. But again, it's a conversation that we have to make people be realistic about what that means for them, but not to downgrade the emotional impact that it had on them.
Okay. Well, I just learned something new because I did not know that. And I know a lot of the women that have so much trauma around, quote, miscarriage are actually having that trauma around a chemical pregnancy. Okay. So when does it stops moving? It stops traveling to the uterus. What are the many reasons why it might do that? Is there many reasons?
Sure. So most commonly, over 90% of the time, it's in the fallopian tube. It's very uncommon to have an ovarian ectopic. It's very, very, very uncommon to have that space where that egg flew back behind my uterus in the peritoneum, somewhere where the bowels are behind, where it gets stuck. That's very, very, very rare. Most of the time, the ectopic pregnancy is in the fallopian tube. Every once in a while, somebody who had a C-section, there can be a C-section scar ectopic where the ectopic gets stuck into that scar. That is highly, highly dangerous for a mom, and it's very rare, but that's another place that people call ectopics. Ectopic means it went somewhere that wasn't normal in the uterus. So that's why they would say these. So some of the reasons why your fallopian tube with that fantastic cilia, go egg, go egg, go egg, and they're gently pushing it down the tube, pushing it down the tube, pushing it down the tube, is because those cilia are not working the way that they should. One reason why cilia slow is because chemically we give you progesterone, which slows down the flow of cilia, like birth control or an IUD that has progesterone in it. It slows down the flow of the cilia. So theoretically, that could slow down the process of an egg moving down the tube and could get stuck if the sperm got into that space, could get stuck in the fallopian tube. That's a theoretical risk. Another reason why it happens is if you had a history of having an infection inside your fallopian tube, if you had gonorrhea, you had chlamydia, you had even normal vaginal bacteria that could get up into the uterus and cause an infection in the fallopian tube. Sometimes that fallopian tube gets inflamed and swollen. It can turn into what we call hydrosalpinx, which is where it's dilated, almost like one of those silly balloons that you use at a birthday party where you make animals out of it. It blows up like that. And so because there's fluid in there, it's a disrupted environment, and that egg does not travel appropriately down the fallopian tube and get stuck in there. If you've had surgery inside your abdomen before and somebody mucked around with your tube on accident and you got scar tissue on the outside of your tube, that could cause trouble. If you have endometriosis, that can cause trouble with the appropriate movement of the egg down the fallopian tube. So any of those issues could happen. If you had surgery on your tube before for another reason, like someone who's trying to have a tubal reversal, like if they had a segment of their tubes taken up because they thought they wanted permanent sterilization earlier in their life, they changed their mind. So then they go ask somebody to do microsurgery and re-anastomose, re-put their tubes back together. That suture line where we re-sew those tubes back together can be sticky. And so you're increased risk for having an ectopic for that reason as well.
So when do you see these patients? How do they find out that they have an ectopic pregnancy?
So it's really sad for a lot of people who think they have a normal pregnancy, right? Like they're like, hey, I'm pregnant, everything's great. And then they start getting spotting or abdominal pain and they come to the ER a lot of times. Or we set them up for their ultrasound for when we think that they're supposed to be 6 or 8 weeks and we don't see it in the uterus, we see it in the tube. And they didn't have any pain, they didn't have any other symptoms, but we see it there. And we're like, oh man, it's in your tube instead of where it's supposed to be. And then we have to deal with it that way. A lot of people unfortunately come in with acute, horrible onset of abdominal pain and pass out or have to call a squad because they were in Target looking at baby booties and they just passed out at Target because their belly filled up with blood because they ruptured their ectopic. So the biggest deal that we have to worry about when somebody shows up to the ER with pregnancy of unknown location is I need a quant level first to tell me, should I see this or not? If my quant level that I draw is 4,000, should I see something in her uterus or not? Yes, 3,000, 1,500 to 3,000 is the cutoff. I should see something in her uterus. If I don't, and I have kind of a mass that's beside my ovary, but it looks kind of mucky, it's not typically like a normal gestational sac. It's not typically like there's a fetus in there. It's typically a disrupted mass beside your ovary, which is where the fallopian tube is. Or she'll have free fluid in her abdomen, which we assume is blood, which means she's bleeding out the fallopian tube where that ectopic was, and they need to go in there and do something about that. So that's how they usually show up.
What time in the process do they usually show up?
Usually 5 to 7 weeks. Because if you showed up to the ER and you had, your quant was only 1,000, so I shouldn't see anything in your uterus because you're early, you're 4 weeks. Your quant's 1,000, you have a little bit of spotting and not bad, just normal cramps in your uterus. And I look in there with an ultrasound and I don't see anything in your uterus because I shouldn't. And I don't see anything in your fallopian tube and I don't know where your pregnancy is. What do I do with that? I have to repeat that in 2 days, repeat that quant level in 2 days to see if it went up the way that it was supposed to or not. Because there's no intervention for me to do this. Most likely is a normal intrauterine pregnancy. We have to prove beyond a shadow of a doubt to somebody that they do not have a pregnancy that could potentially be in their uterus before we start mucking around with medication that we use to treat these or with surgery that we use to treat these, or you could disrupt a early normal pregnancy.
Okay, on to treatment. Somebody comes in, they have it's in the fallopian tube.
Okay, so let's just take your bread and butter. Hey, I had some spotting. I was pregnant. I didn't know. I'm not hypotensive. I'm not like passed out. My vital signs are all very stable. My blood work is stable, and my ultrasound shows that I don't have any blood in my belly. I'm just sitting here with this straw that looks like it has a bubble in the middle of it, which is I have a ectopic pregnancy. There's a couple of reasons why I can give you medication for it. The medication that we use is called methotrexate. It is a chemotherapeutic drug, so I'm very sensitive about giving this medication to women unless we really need to give it to somebody because it's a chemo drug, right? So we have to do it weight-based. We take your height and your weight and we measure it out just like we measure out chemotherapy. The couple of things that we need to make sure are okay with you is that you don't have any pre-existing liver conditions. If you have liver conditions, you can't receive this medication. If you have bad respiratory disease, you can't have this medication. There's a whole bunch of different reasons why you can't have this medication. We have to check your creatinine to make sure that your kidneys work okay, or else you can't have this medication. We also have to make sure that the mass inside your fallopian tube is below a certain amount size. It needs to be less than 3.5 centimeters, or the chance that the medicine works goes down. And also we like your quant level to be under 5,000, or the chance that the medication work, it's not as good of a chance that it's going to work. It's not a complete contraindication, but it's a relative contraindication. So once we see that, I say, hey, listen, I'm really sorry. This is in your fallopian tube. We have options. One is surgery. One is the methotrexate, which is a medication we can give you. You can avoid surgery. We give methotrexate to that person based on their height and weight. They have to come back in 4 days, get their blood drawn again for another quant level, and then they come back in 7 days, 7 days from the first draw, and we do another quant level. If they reduce the amount of HCG that they had from day 4 to day 7, we say the methotrexate worked. And then we get a quant every week following that until it goes to normal. If the quant did not go down the way that it was supposed to, which is 15% from day 4 to day 7, then we have to give them another shot of methotrexate.
What does the methotrexate do?
Methotrexate disrupts actively growing tissue. There's only a few actively growing tissues in an adult woman. Our ovary, like pregnancy tissue, is actively growing. And your gut cells, like your mouth and your stomach and your gut, like your gut cells are actively turning over all the time. So the consequence of taking methotrexate sometimes is that you get really bad stomatitis, like you'll get sores in your mouth, or really bad sore throat, like gut stuff, because it's actively disrupting folic acid, how folic acid is metabolized to make actively growing cells. So we say you can't take any prenatal vitamins anymore. I don't want you to take folic acid. I'm trying to disrupt folic acid so that it will disrupt actively growing trophoblastic tissue, which is placental type tissue in the tube.
So it helps it not grow anymore, and then it dissolves somehow in there?
Yes. Yep. And then we follow that quant level down to nothing. However, if you are not a candidate or you just decided, you know what, I wanted my tubes tied. This was an unwanted pregnancy. I don't want this. I want to just go to surgery. I don't want to do this. Then the surgery options that you have would be to slice open the fallopian tube and suck out the little bubble, or take the entire fallopian tube out on its own. Either of those options are okay, but actually methotrexate, the surgery of sucking it out or the surgery of taking the tube out, impact infertility the same. So it's okay.
Oh my God. I went to school on Janae Davis. She's bringing me to school. So if you want more kids,
yep,
you probably want to take the medication.
Not necessarily. Actually, fertility rates after you take a tube out, because remember what we talked about, which is why I was so listen, the fallopian tube is not attached to that ovary. So people think, oh man, if I don't get rid of this tube, I'm going to do better if you just leave this tube in here. But that's not necessarily true. Because the ovary is not attached to the fallopian tube on the right side can pick up a left-sided ovulation, right? So when you leave that tube in there, who's to say that there wasn't disruption in that cilia, right? So if I let my body dissolve that, it doesn't mean that those nice wheat in the field, go ovary, or go egg. It doesn't mean that there's not a sticky spot that was in there. That tube could be disrupted and not useful for you in the future. So depending on the person, the reason why we would pick methotrexate above surgery is because of surgical risk, right? I don't want to make you have surgery if you don't have to. But the fertility rates following methotrexate versus self-injectomy, which is to take your tube out, versus self-injostomy, which is to make an incision in the fallopian tube, essentially is pretty close to the same. So we do it based on risk. If you came in and your belly is full of blood, you're hypotensive, and I know you have an actively bleeding mass, I need to take you to surgery right now. Like, we're not really talking. You're contraindicated. You're not eligible for the medication. And when we get in there, because your tube is most likely really shot to shit, I'm probably just going to take your fallopian tube out and stop you from bleeding.
And if both fallopian tubes are taken out for any reason, then you are at that point unable to get pregnant. Is that true?
You can do IVF.
You can do IVF.
But you don't have to, yeah. And that's a really sad day. Like, I've had multiple times I've gone in and had to do an ectopic, and then I looked at the other tube, and the other tube is completely a hot mess, which is why I was so sensitive, probably in another episode that we did together, about why sexual health and sexual, just for young people to understand the impact of them getting STDs when they're young, how much impact that can have in their future fertility. Because you can get pelvic inflammatory disease when you're 17 years old, not know it, go up there and muck up your fallopian tubes, and they're just shot to shit. You get one ectopic because your tube was shot to shit, like it didn't work right, and then you can't get pregnant outside of IVF after that. So it's really, really, really impactful for people to just make sure that they're being safe and that they get their STDs treated, and that we just pay attention to our health.
So what's been in the news lately are women not getting the health care that they need in time and potentially dying from an untreated ectopic pregnancy. Mm-hmm. Can you talk about examples of how that might happen?
If you have an ectopic pregnancy that did actually get to 6 weeks, say 5 weeks, 6 weeks, and we do an ultrasound and we see a heartbeat, you're in certain states in a really pickle, because for whatever reason, and again, forgive me for not having the mental capacity to even tolerate these backwards ass ignorant conversations about people saying that you can take this heartbeat fallopian tubed ectopic pregnancy and reimplant it into the uterus. So if you have a heartbeat that's still there, you're not allowed to give methotrexate, or you're not allowed to go into surgery and take that out unless it was a life-saving measure for a mom, because there's a heartbeat somewhere in this, even though it's an abnormally growing, abnormally implanted. There is no way, shape, or form that you could grow a pregnancy in a fallopian tube. It's as thin as 2 drinking straws. Just think about what our uteruses are and what the capacity that is required for the amount of blood flow to get to a placenta to implant. There's nothing that's happening except a placenta growing through, like literally invading tissue, and just going to grow off the side of this fallopian tube and have a woman hemorrhage to death. So, it is beyond fathomable for us to even be having conversations about the potential to sit and watch a person who isn't bleeding to death wait for them to start bleeding to death before we can take him to surgery to save him, because somebody ignorant thought that I can some kind of way go in here and micro implant a pregnancy into a uterus. It's just, it's beyond even, it's insulting to even have the conversation about it. Not for you and I, but I mean, from a legislative perspective.
Yeah.
And it's reckless. It's reckless. It's, you could have possibly had the opportunity to, well, if there's a heartbeat, that's a contraindication to methotrexate, but you had the potential to go in there and not have her entire belly decimated with blood clots, where we're in there trying to like essentially do life-saving measures. You know, someone can, not just when you bleed that we stop it, but you can end up with the consequence of renal failure because you had so much blood in your belly that did not go to your kidneys now because it's all sitting in your belly. You have the consequence of what's called DIC, where you basically used up all the platelets in your whole body to try to make a big clot down there. So now every other spot in your body starts bleeding. Like, you can end up with some horrific outcomes for people over some backward ass, ignorant legislative thinking.
Okay, so you have a woman, there's a heartbeat, it's in the fallopian tube. Mm-hmm. In the best case scenario, you rush her into the OR.
Yes, we take her to surgery. Best case scenario, she's not bleeding. She's like, what the blank are you saying? In my tube, I'm like, yes, and we need to go to surgery right now. I'm really sorry, but we're going to go take this whole tube out. That's the best case scenario.
If there's a heartbeat in a fallopian tube, yes, and a woman cannot get that immediate care,
yes,
in your experience or imagination, how many days would it take for it to become
not
fatal?
Many. I wouldn't say, I hate to use the word fatal because emergent, and everyone's definition legislatively is different than emergent. She's going to 100% start bleeding. Like that placenta is implanted into the side of a super thin, essentially piece of paper straw. And as soon as that placenta grows a little bit past that straw, right, it's going in, it's eating into it, it's going to pop out the other side, and then it's just going to bleed. And the amount of blood flow that it takes to grow tissue in our body is so significant that the amount of vascular flow to that is going to be so significant. The ovaries, which are close to the fallopian tube, are attached anatomically to the aorta. It's not attached to some little veins here, but it's attached to the aorta. The amount of blood that flow that will come from the main vessel in your body carrying blood to and from your aorta and your vena cava, it's just an exorbitant amount of blood. So you could have someone sitting there, and as soon as they start bleeding, when her blood pressure is 80/40, does that count as life-saving measure? She's just hurting a little bit, but I know she's bleeding, but does that count as a life-saving measure? Like, to have to document that, and you can't make a shared decision-making with a woman with her own health care and deciding how it is that she wants to proceed is asinine. But she probably has days before she would start bleeding into her belly. Probably days.
So if you're in one of those states and you go to your emergency room and they tell you that they can't help you, you better get on a flight, basically.
I wouldn't get on a flight. I'd drive.
You would?
I'd drive, because if you're on a plane and they can't get that plane out of it, if you started bleeding, you're going to pass out. If you started bleeding that bad. But at least if you're driving, you can go into an emergency department, the closest one that's there.
Okay, got it.
They have to treat you because of EMTALA. So they could document life-saving measure there, but I can't do surgery on you and over top of Atlanta and Delta.
Okay. Yeah. Okay. That makes sense now that I really think about it. So yes, it is asinine that I'm asking these questions, but I do feel like they're relevant.
They're relevant.
Yeah.
That's why people want to quit OB. It's ridiculous. It's ridiculous.
Yeah. It's also been mentioned that, in the news, that some of these states aren't even offering those trainings anymore. Like, if you're a doctor and you're training to be an OB, you won't learn how to do some of these procedures.
You won't learn how to do an abortion, or you mean an ectopic pregnancy?
But, you won't be taught to treat any of this stuff or even have the knowledge around it. Is that something that is true?
I would, so an ectopic pregnancy surgically is treated the same way that we do fallopian tube removal, the same way we do ovarian cyst, removing an ovarian cyst. It's a laparoscopic procedure. So it's not that you need a special skill to know how to treat an ectopic that's in your belly. We take out masses in the belly space all the time. So I wouldn't say that you need special training to surgically remove an ectopic. A miscarriage, we do in residency programs all the time. The suction aspect of a suction D&C for a miscarriage is the same that you would do for an evacuation for a live pregnancy. So you are learning that, but the treatments for injecting into the heart with digoxin to stop a heartbeat so that you could do your extractions, things like that. I'll unspeak because I haven't spoken to residency directors or been up on what the residencies are actively doing or removing from their training protocol. But ACOG, I think, is adding things to their training protocol as access that we have no matter where you are. ACOG is our governing body, so American College of Obstetrics and Gynecology, adding trainings, videos for anybody who feels like whatever's happening in their personal state is not adequate for them. So our national organization is placing on our websites trainings that are in addition to whatever it is that they would be learning in their residency anyway. So I can't speak to a specific place that has said that they denied training because so many people come in with a miscarriage. The procedure is the same. It's just apparently the reasoning behind it, the ethical problem around what you're doing.
Oh my God.
Yeah.
Okay.
It's not even just a for people who hear it and I have respectfully declined to even talk about this topic with you because it's so heartbreaking to me, and it's so against every single thing that not just that I went to medicine for, but what I have devoted my entire life to care for women. It is such a restriction's not the word. There isn't even a word that I can come up with to tell you the guttural reaction when you are literally holding onto the hands of a woman and you're squeezing blood in through an IV and watching it come out of her vagina until we can get this heartbeat to go away. I can't even describe the agony that a woman has to go through waiting. That's not hard enough already. Like all of it, just to feel so abandoned by your healthcare system that they would let you stay here in this most vulnerable place and position in their entire lives. Her partner is crying, she's crying, whether they wanted the pregnancy or not. Is she going to make it? Is my loved one going to make it, or is she going to die here over this? Like, what that is so against the grain of what we went to medical school for. We are here to care for, support, honor our patients, and it is just an absolute egregious abomination of everything that it is. I can't, I don't even. I've had to do this, and I mean to tell you, it is the worst. I was sick. I almost vomited. I was sick. It made me actively, physically sick. It made me want to quit. And I love this job, and it made me want to quit.
I'm not going to dig farther.
Okay.
I want to, but I'm not going to.
I can't take it. I'm like I just.
No, it's okay.
It's horrible.
The education around what's actually happening or potentially happening in our bodies, we're ill-equipped as women because we were never taught this, or maybe we weren't taught in a way that's absorbable,
But you know what? When I talk about this and when I explain it to people, I'm like, fuck me, we are such badasses. Do you know how many things have to go right in the perfection of my uterus, ovary, and fallopian tube? Do you know what miracle has to happen for this little piece of pepper to bubble itself off of an ovary, fall down into the abyss where my bowels are behind my uterus, ask some kind of a cornucopia that's lined with wheat-lined hair to pick up a piece of pepper and have it some kind of way meet with this little ass sperm in a tube and then go down and implant and create life into my uterus. It's just such a miracle of, it's just a miracle of circumstance that this happens on the daily, that we have this happen on the daily. So even though people get ectopics, it's not very often. Most of the time, if we have a pregnancy of unknown location, we can't find it, and the quants don't go up the way they're supposed to, most of the time, it's a miscarriage. It's not an ectopic pregnancy. Our job is to prove to the woman that it's not in your tube. That's our main objective. It's not to go and try to give you minutes. It's to prove to you that you have what probably 90-something% of the time happens, which is a failed intrauterine pregnancy, that we don't have to worry about you blowing your tube out and bleeding into your belly. That's our goal. But most of the time, it's a seamless thing that happens. It's really incredible. It's just amazing. And for somebody to be so ignorant to think I can just pluck this out of a tube and plop it into a uterus is just so ignorant. It's beyond me. It's beyond me. But besides that, we're just badasses in general. So I'm just going to say that.
Okay. Last question on ectopic pregnancies.
I'm sorry. I know you only want to talk for like Janae.
No.
You're gonna have
no, I will take all of it.
You have to chop this up, girl.
No, even if I have to chop it up into a couple episodes, I'll do it. Okay. They get the medication. They get the surgery.
Okay.
In either case, they're trying to build their family. How long do you suggest for them to wait before they start trying again?
So it depends. If somebody had a whole belly full of blood and this was like really a traumatic thing and oh my gosh, and did we even get all the tissue because it plopped out into the belly space? And I'm not even sure I got it. We need to follow your quantitative HCG levels down until they're back to normal again. So that we know that when you restart over again and you try, that the hormone foundation was appropriate to make the lining in your uterus acceptable for a pregnancy. So if we just go to surgery and you try to get pregnant the next day, that's not appropriate. Second, I just cut or burned with cautery your fallopian tube. There's no stitches that we're putting in there typically. We do that with burning and cautery. So it's just held together by like hopeful charred glue. Hopeful charred glue. Well, that's right next to your vagina. So I don't need his ding ding up there whamming around on your cervix, stretching out my hopeful charred glue. And then all of a sudden she starts bleeding again because she hasn't healed all the way, right? She didn't regrow more tissue. So it's a more of a structural problem. People are like, but we really want to be together. We're really upset. But I'm like, please, for the love of all things holy, please just let my charred glue settle in some actual tissue so that you're not bumping things around in there and tearing and having her bleed in her belly for that standpoint. So if your quant level is back to normal, let's say your quant was only 800, you had an ectopic, it was only 800, I took your ectopic out, and 2 weeks later, your quant's back down to nothing, I'd be like, hey, can you give me 6 weeks to just let that tube heal up, then go ahead and have at. But let's say somebody had a really far along ectopic that plapped into her belly. Somebody left a little tiny bit of trophoblastic tissue in there. Her quants take longer to go down. They take 6-8 weeks to go back down to normal. We should not start pregnancy until we have a completely negative quant level. If that quant level starts to go back up, not just go down slowly, but go back up, we are concerned about having something called gestational trophoblastic disease, which can be almost like a cancer, neoplasm that happens from pregnancy tissue.
Because the tissue is rotting in there and it's still
in layman's terms, it's like a placenta cancer that can grow.
Oh, okay.
Sometimes when you have a ultrasound and it shows your quant level is 150,000 and you should only be 4 weeks, it looks like grapes are inside the inside of somebody's uterus. That's like placenta cancer. And that requires chemo. And that goes directly for a lot of people to their brain. You can have metastasis to your brain for that. Like, that's why we're like, we need you to come back to make sure your levels are where they need to be.
But is that actually cancer cells or is it like cancer?
It is like a cancer. Yeah. It's essentially like a cancer. It's actively growing tissue, right? Cancer is actively growing. So it's from a trophoblastic foundation, but it's a cancer that can metastasize and go to different places in a woman's body. And it can just be deadly. It goes to her lungs. Like, it can be very, very scary very quickly.
Okay. And then if they suffer from endometriosis and they had an ectopic, what are some of the things we need to know about that?
That's not good. If you have endometriosis and you already got an ectopic and you've never had a healthy pregnancy before, I'm probably going to take your tube out, and you probably already have disease in your tube. You are increased risk. People are like, well, if you hadn't done this surgery for me, then I wouldn't have had the ectopic the next time, or you messed up my fertility. But if you have endometriosis and I have to take your tube out for ectopic pregnancy, your other tube might be messed up just because you have endometriosis, not because your infertility was messed up from something someone did in surgery. There's a reason why you had the ectopic in the first place. Do you know what I mean?
Yeah.
Something intrinsically might have just been wrong with your fallopian tube. So a lot of people say, you know what? I don't want to waste 6 more months or 12 more months trying to worry about getting pregnant through a tube that maybe doesn't work. I just want to go to infertility and try IVF, because even though it's 20 grand or whatever it is, my chances for pregnancy of removing an egg and sperm in a dish and sticking it in my uterus, I have a 60 to 70% success rate, but I don't know what my success rate is going to be on a possibly good or not good tube. Even if we do a chromotubation where we squirt dye through the tubes, where we're trying to open the tubes up, doesn't mean that the cilia, the little wheat, the little go egg, little wheat, doesn't mean that the little wheat works. It just means that the tube might be open. But if you can't get the little hair-like cilia to bring the egg to where it needs to be, then it doesn't matter that your tube's open. If the cilia are sticky, if it's like somebody went down with a mower and mowed all the wheat down, then I don't get this amber waves of grain. You know, that's what I think of. Yeah, go cilia. You don't get that. You got the mowed down wheat. The cows are eating it, girl. They've been eating it. We made bread out of it. It's gone. The wheat's gone.
Dr. Janae, I'm telling you that Kelly and I on a regular basis just sit around and dream up potential reasons we could throw at you to see if you'll come back.
I can't wait to come back.
We're like, do you think she'll come back for this? And we're like, oh no, I don't think she's going to say yes to that.
Yes. The short of it is this. We are incredible. There is a 50 million things that happens to pop an egg off of your ovary, your fallopian to pick it up, and to meet a sperm. If that doesn't happen and it gets stuck in your tube, I can give you medicine if it's not too bad, or take your tube out basically if it's really bad. And then if you want to get pregnant again, because whether I give you medicine, whether I take your tube out, or whether I slice your tube open, the chance for your fertility is about the same all the way. If you have endometriosis on top of that, it's not good news. I'm not going to lie. Like, you might want to just decide to go see an infertility specialist and decide if you want to skip trying to use that tube, or shorten the interval of time that it is that you want to try to use that tube, with the realistic expectation that this tube might be jacked. That's the short of ectopics. I could have just said that, and then I wouldn't have taken up your whole 2 hours.
No, but then we wouldn't be so much more educated.
Well, then I went off on my little tangent, so sorry about that.
No, this is good. I'm so happy to see you.
You too.
God, I can't believe you live in it is so weird. You live in my hometown now, and I'm not there.
No. And I just went to breakfast with Kelly. I don't know if she told you.
Sometimes she tells me, but she knows it makes me really jealous. So
okay, she didn't say. Yeah, we just went because I see you trying to get on her calendar. I'm like, my schedule's just a shit, but that's okay.
You know, it's because you're a busy doctor.
I don't know about that, but I'm trying to get it done like Carrie and Kelly. I'm trying to get it done.
Mm-hmm. Trying to take over the world.
Well,
one episode at a time.
Yeah.
Dr. Janae, always a pleasure. I've just gone to medical school for 2 seconds.
No worries. You call me any other topic. I can't wait. And if somebody, like I said, has some questions, just shoot them over to me. I'm happy to answer.
My friends, thank you so much for tuning in. I appreciate you so much. If you'd like to be on the podcast, just send me a DM or email me, Carrie@wrapyourheadaroundsilks.com. This is for you guys. It's for the worldwide community. So if you have a story that you'd love to share, please reach out. I'd love to have you as a virtual student. So if you go to the show notes, there's links for all of my online resources, free mini course, comprehensive beginner to intermediate, and aero rehab as well. I'd love to have you guys there. And check out Greener Grass. It's the podcast that I do with Kelly McVeigh. And we talk about so many things that you might care about. And then we also just gab. We have so much fun. Please leave me a 5-star rating and review. It makes such a huge difference. So I would appreciate that with all of my heart. And thank you so much for tuning in and listening. Over and out. This is Carrie with Wrap Your Head Around Silks. This is the Expecting Podcast.